Hello there. Good afternoon. I wonder if people can hear me now. It's Mitchell Warren from AVAC.
Yes, we can hear you.
So I have done an introduction to this whole call on mute. I apologize. Let me start again and try to catch up for some lost time. I'm very sorry, all. It's Mitchell Warren from AVAC, and we clearly had some technical difficulties this morning. But I'm delighted to welcome everybody to this call following up on the conference on retroviruses and opportunistic infections that took place just last month in Boston. And as we do each year, a series of webinars to pick up on some of the key themes and issues that get raised during the course of the conference. Hopefully many of you will know just a couple of weeks ago we had the first in the series focused on the dapivirine vaginal ring, one of the newer forms of PrEP that is in development, and presentations both at CROI and on the webinar about the open label extensions, and that call recording and slides are all available online. And this picks up on a slightly different issue related to HIV risk of acquisition during pregnancy and in postpartum phases, and really important because we'll hear both the data that was presented at CROI as well as some of the implications for prevention and certainly for PrEP in pregnancy and postpartum from our two wonderful presenters. I'm delighted to have two presenters who I'll introduce in just a moment. Just to give you a quick sense of the schedule, I'm going to turn it over to them in just a minute to present. The line is muted, as I was a little while ago, but people can send in questions at any point on the ReadyTalk chat feature, or you can email to avac@avac.org at any point. And then after Kerry and Renee are done presenting, we'll go in and certainly feel free to open the line and people can ask questions directly. So that is kind of the run of show for now. And without further ado, what I'll do is really turn it over to two people, both based officially at the University of Washington. One physically in Seattle right now, so very early morning, to Kerry Thomson, who we're going to hear present first. And then she will hand it over to her colleague, Renee Heffron, also at the University of Washington, but currently in Maseru, Lesotho, so on the other side of her day. And she'll pick up on some of the implications of what, the data and what it all means and what we all should be thinking about in terms of work for the future. The one thing I should also highlight is how we talk a lot about clinical trials and research findings, and you know, it's always many questions that get asked and answered in the course of a trial. And what you'll see on this initial cover slide as I turn it over to Kerry and to Renee is that this comes from two studies that were conducted over a number of years, the Partners in Prevention study and the Partners PrEP study. And you will have all heard over many years different findings coming out of that. And it really just speaks to how rich these studies are, because they really are able to address so many different issues. And you'll hear that as we go through this presentation. So without further ado, I'm delighted to welcome Kerry first. And thank you again for an early morning start in Seattle. And I'll turn it over to you.
Good morning or afternoon, everyone, wherever this finds you. Mitchell, can you just confirm that I'm coming through okay?
You are coming through perfectly. Thanks so much.
Great. Well, thank you so much for that kind introduction. And I first just want to thank our colleagues here at AVAC for inviting us to present our research today. And thanks to all of you who are taking time to listen today. Next slide, please. So for women of reproductive age, HIV is a leading cause of death worldwide, representing about 12% of causes of death. One hypothesis for the high HIV incidence among reproductive age women is increased susceptibility during pregnancy and postpartum. Results from a recent meta-analysis calculated a pooled HIV incidence rate during pregnancy of 4.7 per 100 person years during pregnancy and 2.9 during the postpartum period. These estimates exceed what we would usually see in high-risk groups, such as women engaging in transactional sex and women in HIV serodiscordant partnerships. Next slide, please. Here, this slide summarizes a number of previous studies that have explored pregnancy as a risk factor for HIV. And as you can see, there have been mixed results, ranging from studies showing no association between pregnancy and HIV to a doubling of HIV acquisition during pregnancy. There have been a few studies specific to the postpartum period as well, with results being similar in their inconsistency. Sexual behavior often changes during pregnancy and postpartum, most commonly with reductions in sex frequency and condom use. And so this makes it imperative that analyses of pregnancy and postpartum periods use frequently collected data so that changes in sexual frequency and condom use can be incorporated and do not end up obscuring any increased HIV risk from pregnancy itself. Prior analyses have accounted for sexual behavior in different ways, and this could at least partially explain the differences in results that we've summarized here. Next slide, please. When we consider a woman's reproductive lifespan and the total years on average that women spend being pregnant or postpartum, the total duration of risk could be substantial. For example, in Kenya, life expectancy for women is around 63 years, and women have an average of 4 children each during their lifetime. Adding in about 1 year of breastfeeding for each child, women would spend an average of 7 years pregnant and breastfeeding. And these 7 years account for 10% of a woman's life, or 20% of her reproductive years. So in locations like Kenya, where women bear a heavy burden of HIV and spend a substantial proportion of their lives pregnant or breastfeeding, fully understanding the possible link between pregnancy and HIV could have important implications for HIV prevention. And that's what motivated the current study. Next slide, please. And so our objective was to estimate the probability of HIV acquisition per sex act during periods when women were pregnant or postpartum, and then compare these probabilities to time periods that were unrelated to pregnancy. Next slide, please. We used longitudinal data from HIV-negative women participating in 2 randomized controlled trials among African mutually disclosed HIV serodiscordant couples. These are the 2 studies that Mitchell just mentioned in his introduction. And just to summarize, in both studies, HIV-infected partners were not using ART at study enrollment. The studies tested for HIV and pregnancy frequently. Sexual behavior was captured monthly, and genetic linkage between seroconverters and their study partner were determined using sequence analysis. The primary objective of the first study, the Partners in Prevention HSV-HIV Transmission Study, was to evaluate the efficacy of daily acyclovir to reduce HIV transmission from partners co-infected with HIV and HSV2. However, there was no effect from this intervention. And the second, more recent study, the Partners PrEP Study, evaluated the efficacy of daily oral PrEP to prevent HIV acquisition, and this did demonstrate a significant reduction in HIV incidence with oral PrEP. Next slide, please. Among the initial HIV-negative women followed in these 2 studies, for the current analysis, we included only women ages 18 to 49. In addition, we censored study visits once a woman's male partner reported ART initiation, and if a woman acquired an HIV infection that was not genetically linked to her male study partner. And our outcome of interest for the current analysis was first evidence of HIV infection. Next slide, please. Our exposure of interest was a time-varying reproductive stage, which was disaggregated into different phases of pregnancy and postpartum, as shown here on the slide. Pregnancy testing occurred monthly in the Partners PrEP study, and as clinically indicated for HIV-negative women followed in the HSV2 cohort. For 97% of the pregnancies that occurred, we were able to assign a pregnancy start and end date using the date of last menstrual period and the date of delivery or loss. For the remaining pregnancies, we used information about last menstrual period and gestational age to estimate the dates when pregnancy started and stopped. We then used these dates to categorize a woman's time in the study according to how much time she spent experiencing early pregnancy, late pregnancy, postpartum, or was experiencing time unrelated to pregnancy. And then this was entered into the model as a time-varying exposure. We defined early pregnancy as 0 to 13 weeks, late pregnancy as 14 weeks to pregnancy end, and the postpartum period was defined as the first 6 months following delivery for a live birth, or shorter if the pregnancy ended in a loss. An additional important factor in all of our models was the total sex acts, which were reported on a monthly basis within the study partnership. Next slide, please. For this particular question, given the importance of accounting for sexual behavior, we selected methods that would calculate the HIV risk with each sex act. We used a complementary log-log model to calculate the probability of HIV acquisition per sex act, and then compare these probabilities. The model was adjusted for HIV plasma viral load of the male partner, dispensation of active PrEP, which was relevant to those women enrolled in the partner's PrEP study, condom use, and the woman's age. We centered age and male partner viral load, and so the reference group for the absolute probability estimates for HIV acquisition, which I'll be presenting shortly, represent a condomless sex act by a 25-year-old woman who is not pregnant, not using PrEP, and whose male partner has a viral load of 10,000 copies. Next slide, please. The current analysis included 2,751 women. The median age was 32 years. At enrollment, HIV uninfected women reported a median of 4 sex acts with their study partner in the previous month, and 24% reported at least 1 condomless sex act in the month prior to study enrollment. Nearly a quarter of women followed were pregnant during follow-up. A total of 686 pregnancies were followed, and 62% of these resulted in a live birth. Next slide, please. When we looked at sexual activity by reproductive stage, we found a trend of decreasing sex frequency during pregnancy-related periods compared to time unrelated to pregnancy. And after adjusting for age and relationship duration, sexual frequency was significantly lower during late pregnancy and postpartum compared to non-pregnant times. Further, when we look specifically at sex acts without a condom, the rate of condomless sex was highest during the early pregnancy period. And after adjusting for age and relationship duration, condomless sex was significantly higher during the early pregnancy and significantly lower during the postpartum period. Next slide, please. HIV incidence overall was 1.6 per 100 person years. And when we looked specifically at women when they were not pregnant or postpartum, HIV incidence was 1.25. And during pregnancy-related periods, all aggregated together, the overall HIV incidence was 5.37. Next slide, please. The graph here shows our calculated estimates of HIV infectivity per 1,000 sex acts. We found that the probability of HIV infection per sex acts increased as pregnancy progressed and was highest in the postpartum phase. As you can see here, infectivity per 1,000 acts was 1.05 during time periods unrelated to pregnancy or postpartum, and then risk per act steadily increased as pregnancy progresses, with an infectivity of 2.19 in early pregnancy, 2.97 during late pregnancy, and 4.18 in the postpartum phase. So when we look at these results in relative comparisons, the results of our adjusted model suggest that the risk of HIV acquisition per sex act is almost 3 times higher during all pregnancy-related stages combined compared to time periods unrelated to pregnancy. Next slide, please. And then when we disaggregate into the separate stages of reproductive stages that we are interested in early and late pregnancy and postpartum, we see that the risk of HIV acquisition per sex act is almost 3 times higher during late pregnancy and nearly 4 times higher during postpartum, even after adjustment for factors that are related to HIV transmission. And as you can see, these results were highly statistically significant. Next slide, please. We conducted a series of sensitivity analyses to assess the impact of any potential misclassification or bias. We altered our outcome to be an estimated date of HIV infection rather than the earliest date when HIV was detected. We excluded women randomized to the active PrEP arms. We excluded women who never experienced pregnancy during follow-up, and we included a longer postpartum period of 6 to 12 months after delivery. Results from all of these sensitivity analyses were similar to our primary results, which I presented on the prior slides. Next slide, please. In summary, there was an increased risk of HIV acquisition per sex act as pregnancy progressed, specifically a 3-fold increase in late pregnancy and a 4-fold increase during the postpartum period. These results account for decreasing sex frequency during pregnancy and postpartum, and they held steady during multiple sensitivity analyses. The results of this per-coital act analysis suggest that biological changes associated with pregnancy and postpartum contribute to increased HIV acquisition risk. However, importantly in this study, we did not directly assess any biological mechanisms that could be responsible for increased HIV susceptibility, such as changes in hormone levels, activation of innate immunity, and suppression of the adaptive immune system. This here concludes the summary of the results from the analysis that we presented at CROI. And I'm going to stop here and now turn it over to Renee to discuss the public health implications of these results.
Great. So thanks so much, Kerry, and thank you everybody for joining today. I wanted to, when we presented these results at CROI and also in the paper that's up online now, but given that AVAC asked us to do this webinar, we wanted to spend some time giving you a little bit of our thoughts about the implications for these data, and I wanted to also give just a bit more data to support the implications and a bit more about the public health context. So what we have with this study that shows an increased risk of HIV during pregnancy and postpartum periods is actually points us to some tremendous opportunities to promote HIV prevention and care in antenatal and postnatal care. And when Kerry and I and our team thinks about these opportunities, we came up with these 4 different opportunities. The first is for counseling on increased HIV risk during pregnancy and postpartum. The second is to promote repeat HIV testing during maternal health visits. The third is an opportunity to continue identifying HIV-infected male partners and to link them to HIV care and ART initiation. And then the fourth is to promote oral PrEP during pregnancy and postpartum. And so I'll just spend a couple of minutes talking about each of these opportunities. Can you go to the next slide, please? So in terms of counseling on increased HIV risk during pregnancy and postpartum, WHO recently released an updated set of recommendations for antenatal care that focus on a positive pregnancy experience. And in this set of recommendations, they do recommend at least 8 contacts between a pregnant woman and her provider prior to delivery. And so if you're able to have at least 1 or 2 contacts and even up to 8 during this time, that presents many opportunities for HIV counseling and initial HIV testing. And it's worthwhile to think about what sort of counseling messages could be developed to really help providers talk with women about HIV risk during pregnancy. This counseling could include descriptions based on the data that were presented that a woman's risk for HIV increased during pregnancy and postpartum. And these are due to changes in sexual behavior and also likely due to due to the changes that their bodies undergo while they're being pregnant and postpartum. Next slide. And so this slide is showing you the estimated frequency of HIV testing and counseling coverage among pregnant women. And I've put a couple of arrows on a couple of the sets of the bars for us to focus on. But on this graph, there's 6 different years of this survey that are shown. And in general, I think the good news is that we do see increases in testing and HIV testing and counseling coverage as we go forward in time. But we also see quite a discrepancy, I think, regionally. And so in the Eastern and Southern Africa area, if you look in the year from 2013, an estimated 74% of women who were pregnant had an HIV test during their pregnancy. That's higher in Eastern and Southern Africa, where we know that there's a greater burden of HIV worldwide. It's higher than the total far on the right that's shown for low and middle income countries. And so, where we have a diverse burden of the HIV epidemic if you look at all of the low and middle income countries. So we are seeing, good coverage of HIV testing, but also room for improvement. Still, 26% of pregnancies go without an HIV test in Eastern and Southern Africa, where we know that the burden of HIV is higher than in most areas. So next slide, please. In terms of thinking about, and I also wanted to show this slide, which shows the number of new HIV infections among children and the coverage of ART for PMTCT. So if women, so one reason that mother-to-child transmission of HIV happens is because women are not diagnosed with HIV during pregnancy because they are not tested. And so there is no opportunity for antiretroviral initiation during the pregnancy, which would prevent onward transmission to the child. So you can see on this figure on the right, the line, the brownish line that goes down, represents the number of new infections among children. And so this is a good trend that the number of infections are going down, but we still, there still were over 100,000 new infections in children just last year. And this is sort of mirrored by the inverse picture of the red bars, which is the coverage of antiretroviral medications that are provided to prevent mother-to-child transmission. So, as HIV testing during pregnancy increases, there's more opportunity for PMTCT to prevent onward transmission to children. But what I wanted to point out to you is that the new HIV infections among children represent really missed opportunities for HIV diagnosis and or ART initiation during pregnancy and also during postpartum. We can go to the next slide now. So another opportunity that we discussed was the opportunity for repeat HIV testing during pregnancy and postpartum. And this is really aligns with WHO recommendations. The recommendations for high HIV prevalence settings are that there be provider-initiated testing and counseling for women as a routine component of the package of care that's available in antenatal, childbirth, postpartum, and pediatric care settings, but also that there be repeat retesting in the 3rd trimester or during labor or shortly after delivery. And then that there be periodic retesting of lactating mothers who are negative throughout the period of breastfeeding. Those are for high prevalence settings. In the low HIV prevalence settings, the recommendations are for provider-initiated testing and counseling on pregnant women, and for HIV testing for pregnant women who are within key populations or who have partners with HIV or partners that are from key populations. So these are the recommendations. So you can go to the next slide. And countries have adopted these guidelines to varying degrees. I'm just showing from a study in Kenya that was published fairly recently, where the Kenya Ministry of Health did adopt the WHO guidelines for repeat testing in 3rd trimester and had a guideline change in 2012. But this study that was recently conducted looked at how many women who were attending antenatal care actually had a repeat test in the 3rd trimester. And in this study, they found that less than 10%, 9.6% of the women who could have had a second HIV test actually did. And what they point out, and what the figure on the right, which is drawn directly from the article, what it points out is that there's gaps that include that either women come in and have their first HIV test too late, so their first test is in the third trimester and there's not space for a second test during the third trimester, or they come back for their antenatal visits too soon, so it's not yet the third trimester. And some of them are missing, and some of them do come back within the right time frame and could have a second test, but it just gets missed. Either the clinic is too busy, or the provider forgets, or the woman opts to not have it. Various scenarios. So this is, I think, pointing out some of the gaps in actually implementing this repeated HIV test during the third trimester. We can go to the next slide. So the third opportunity that we wanted to think about was engaging men more in HIV testing, with onward linkage for them to HIV care or prevention, depending on what their result is. And there is a lot of work going on to understand factors that affect men's uptake of HIV testing. And I've put just a few of the factors that were that came to the forefront from a recent publication from the Search study team, which is a very large population-based study. And in Kenya and Uganda, the team found that men's employment schedules, some gender norms, including the idea that healthcare seeking is for women, and also the idea that men test by proxy, that is, they assume that their HIV status is the same as their partners. These are factors that affected men's uptake of HIV testing and were challenges to having men actually tested themselves for HIV. Can go to the next slide. And so we do need more innovative approaches, and I know that a lot of people are working to test out innovative approaches and to develop innovative approaches. But just to put up there, a couple of recent studies have found that home-based couples testing has been successful in getting more men to test for HIV. This was done in a study where they compared it to clinic-based testing, and then also using HIV self-test kits, including having those self-test kits brought home by pregnant women and given to their partners. And so these are some interventions, some new approaches to engaging men that have been tested and are seeing success in some settings. You can go to the next slide. And so the fourth opportunity really is to implement PrEP and encourage PrEP use during pregnancy. And last year, the World Health Organization put out a new guidance called Preventing HIV During Pregnancy and Breastfeeding in the context of PrEP. And there's a picture of that document on the right. And the WHO guidelines say that the existing safety data support the use of PrEP in pregnant and breastfeeding women who are at continuing substantial risk of HIV infection. And this guideline was developed after a very detailed systematic review was conducted, looking at all of the existing safety data that we have about PrEP, which primarily comes from data from women who are living with HIV who use tenofovir as part of their antiretroviral regimens. So looking through all of those data and really summarizing what's been seen. I also did want to point out, though, that the guidance also says that calls for the active surveillance of mother and infant outcomes during PrEP use and pregnancy and breastfeeding, and that these should be part of a PrEP program so that we continue to monitor for maternal adverse outcomes, adverse birth outcomes, and adverse infant and child outcomes. And so these are all contained in this WHO technical brief. And we can go to the next slide. So there's a number of countries now that have PrEP-specific guidance, and we've recently been working on a review of this guidance to understand how many of them actually talk about PrEP use during pregnancy specifically. And there are 4 countries with PrEP-specific guidance that also contain pregnancy-specific guidance. These countries are South Africa, Kenya, Swaziland, and Uganda. and these are countries with generalized HIV epidemics. And so among those 4, 3 of them recommend PrEP to be used during pregnancy and breastfeeding, quite in line with the WHO guidance. The guidance in South Africa is a little bit different, and it does not recommend PrEP use in pregnancy or breastfeeding, but it does give leeway. It does also say that as the risk of seroconversion during pregnancy is high, the risks and benefits of PrEP should be discussed with potential PrEP users, allowing women at high risk of HIV acquisition to make an informed decision regarding PrEP use. And then their guidance actually goes on to talk about their interest in having more PrEP safety data, and this it also aligns with the WHO call for more programmatic data that gives surveillance data of safety during pregnancy and postpartum for PrEP use. And then there are also a number of countries with concentrated HIV epidemics in key populations or in certain subregions, and most of these guidances about PrEP actually state that PrEP can be used during pregnancy, but consideration should be given to whether there is an added benefit of PrEP in the context of ART use and viral suppression. And many of these countries are in the context of having coming very close to meeting the 90-90-90 goals and having high rates of viral suppression in their people living with HIV. And so it's an important consideration to think about the value added of PrEP in the context of viral suppression, and really important to consider the preferences of the woman who is pregnant and what PrEP would do for her during her pregnancy and postpartum. So we can go to the next slide, which this is just a summary of these implications, which, I do think that there are great opportunities to engage pregnant women in HIV prevention, beginning with HIV testing, and we need to keep working towards reducing that gap and meeting more pregnant women with HIV testing that works for them. We know that there are structural and individual barriers that present challenges with HIV testing, and we need innovation to overcome barriers for women and men. And then finally, we have a recommendation. Oral PrEP is recommended for use during pregnancy and postpartum, and countries with PrEP guidelines are often permissive of PrEP use in pregnancy, with options for women to weigh their personal preferences. But not all countries with large HIV epidemics among women have adopted the WHO recommendations. Next slide. So I will end there talking about the implications. But Kerry and I both want to especially acknowledge all of the participants who were part of these very large randomized clinical trials. In total, there's nearly 9,000 HIV serodiscordant couples who were part of these trials, and the information that they gave us and their data continue to just be so amazing and help move the field along so much. There also were, of course, a number of funders, and we wanted to acknowledge them. I think you can go to the last slide now. Yeah, so that's all from our formal presentation, and go ahead, Mitchell. I know you're ready to open it up for questions.
No, thank you so much, Renee and Kerry. That was absolutely terrific overview of the data collected throughout this work and then the implications, and really appreciate you having more time to kind of explore those. Lots of questions have come in, and I'm going to try to cluster them. Some are about the earlier part of the findings for Kerry, and some about the implications. And I'm just going to ask a couple. People should still feel free to send their questions in on the chat feature or via email, or in just a moment after a couple of questions, I'll pause and people can hit *7 to unmute your line, ask your question, and then *6 to go back so we can keep the line nice and clear for recording. One question toward the very beginning, Kerry, and it relates, I think, probably to some of the implications too, and that is how generalizable are all of these findings? And the question came up back here geographically. So I'm going to go back to your slide to show the 2 studies from which this all derives, the Partners in Prevention and the Partners Prep study. And someone asked a question, so there's obviously a lot of Kenya and Uganda because they're in both of these studies, and then the other countries. So one question about, did you see any difference across different countries? And the other question someone flagged early on was, obviously these studies have gone on for quite some time, back to 2004, and if there's any sense, and again, it may not be that you're able to do it in this exact analysis, but is there any sense of difference over time? So basically, differences in time and space, I guess, would be the way to ask that.
Sure. I just want to confirm you're hearing me okay again?
Yes, absolutely. You're back.
Okay. Excuse me. That's a really good question, and thank you for bringing us back to the map. We were not able to look at country-specific comparisons, in part because of power. I will say that we did look at the results by cohort, and the overall directions of effect and the overall risk estimates were quite stable when we looked at things individually by these two cohorts, and then ultimately we combined them to maximize power for the final analysis. In terms of generalizability, we don't have any reason to think that sexual behavior or pregnancy has really changed over time. When we think about the HIV epidemic, a big thing that has changed since the origin of these studies, certainly the first study, is ART initiation, which we, and the effects on viral load, and we address that by adjusting for viral load and then also censoring women, in other words, excluding women from the analysis once their male partner initiated ART. So those are two big things that we were able to account for.
Great, thank you for that. And another question that I think it's certainly part of the conclusions, but someone asked, why focus on pregnancy and postpartum to begin with? And so I guess the question in part is did you all go into this, even beginning back with Partners in Prevention and then Partners Prep? Were there already reasons to believe that there was this increased risk, or is this something that you're only now looking at? So basically, how surprised are you? Does this confirm what you were thinking, and that's why you looked at this analysis, or did this analysis emerge and all of a sudden this is a new finding? So someone just looking for the context and history of it.
That's a great question. In terms of, I'll answer the second part first. So if we go back to that forest plot that was on slide 3, this really summarizes some of the history behind this question, and that there have been individual analyses that have looked at this question, but there is a lot of statistical nuance for this particular question because of the importance of sexual frequency. And so there was not a very detailed, robust per act analysis. And that is really the contribution that we've made here, and that we were able to leverage these two detailed cohorts where sexual frequency was reported monthly, and we can really account for the fact that sexual activity is changing during pregnancy and postpartum. The results of the studies shown here on the forest plot have often brought us to wonder, is it truly something that's happening biologically? Is there something that's happened physiologically with all the changes that accompany pregnancy and postpartum that's increasing HIV acquisition whenever a woman engages in a sex act during those time periods? Or are we seeing these mixed results because the sexual activity is changing? And so this per act approach is one way of really isolating the risk per act, and gives us more confidence in the conclusion that it seems to be something biological that is going on here and leading to the increase in HIV risk. So we were, when we went into this, I think we believed that there was going to be an increased risk, and we wanted to substantiate that with these robust methods. we were surprised that the highest risk period was postpartum. And as Renee addressed throughout the public health implications, that's one thing we're trying to highlight with these results, is because often that postpartum period is somewhat, from a maternal perspective, is somewhat neglected because the focus starts shifting to the child and less onto the mom. And historically, we've just had less focus on HIV prevention and specifically HIV testing as a woman gets farther and farther away from delivery.
It's super, super helpful, Kerry. There are a number of questions that have come in related to that, the implications. And it's funny, you just focused just at the end of your comment there about the focus shifting to the baby from the mother. But a question came in about male partners, and someone flagging, Renee, your mention of that as one of the opportunities, and a question about the possibility of routine partner testing for pregnant women, and are there experiences about implementation of that? Is that something that, and again, if it's not something you all have done directly, are you aware of programs or interventions that have tried to focus on that, and with what degree of success?
Yeah, thanks, Mitchell. I think that this is not something that I have focused on specifically yet, but I do know that there are, a number of people are thinking about this and trying out new things. One thing that I know we have learned is that bringing men into antenatal clinics is not often a place where men feel comfortable, and so thinking about settings where men feel more comfortable also makes sense. But I think that linking men to testing either through women bringing home information from antenatal clinics, or people from clinics going out to homes where they are welcome and invited to talk with families about HIV testing, are opportunities that are being explored, and we should know more about how those fare in the coming years.
Great. And another question came in that I think is really provocative and important. And I don't know, I think we do have some people from WHO who may be either on the line or had dialed in. So I'm not sure if any of them want to add to it, but I'll start with you, Renee. Someone asked what seems like a very simple question. Why wouldn't you offer PrEP to someone who's given this information you're presenting, who's pregnant or postpartum, because if she gets infected, wouldn't she be put on the same drug anyway? So why wouldn't you want to offer PrEP? And I guess a question kind of to the issue you raised on the slide about the guidelines, but basically, wouldn't you be providing the same pill if she got infected?
So that's a really good question, and let's see where to start. I think, first of all, when we think about pregnancy, we're often quite careful about and are conservative about medication use during pregnancy. And when we're thinking about PrEP is a preventive therapy, and so a woman has to consider, her HIV exposure, as well as, side effects that she might feel from PrEP when she's initiating PrEP during the first month, as well as symptoms she might be feeling with pregnancy, and also, and other, how does she do adhering to a medication every day during pregnancy, and there's just a number of factors to consider. And so there's this risk to benefit calculus that I think women go through when you would decide if PrEP is something you want to use during pregnancy. And it's a different risk to benefit calculus than you would use if you were infected with HIV and you knew that antiretroviral therapy was good for your own health and would protect the baby from becoming infected. So that's that calculus is different for prevention versus a therapeutic for treatment. So does that? I don't. If there are others.
That's a great response, and I will say and we can certainly put these links up when we post the recording and the slides. And I think you mentioned some of this, but both WHO and the the PEPFAR Scientific Advisory Board have both been quite supportive of the provision of PrEP in pregnancy, but it does come down to national guidelines and regulatory approvals. And so maybe just and we can post both the PEPFAR guidance and WHO's. But I wonder, Renee, just picking up on that, because someone else asked a great question here, do you think this calls for, does this really speak to the need for additional data around safety within pregnancy and postpartum to help support any normative guidance or national programs? So is there, is it something that, certainly it's an individual choice. We want to make that information available as you described in the South Africa scenario, but is there a specific need, do you think, for more data around PrEP in pregnancy?
Yeah, thanks for that. I do think that there is a need. So the data that we have, and I alluded to this just a little bit, the data that we have is primarily from women who are using tenofovir as part of HIV ART regimens. And so, and there's quite a bit of data from that, and we even have data looking at, looking at the pregnancy outcomes as well as the infant growth characteristics during the first year of life. So we can look at how well infants who were exposed to tenofovir in utero do in terms of their height and their weight and their head circumference throughout the first year. And those data pretty much in aggregate, those data pretty much do not give us cause for concern about safety when tenofovir would be used by HIV negative women for as PrEP. But we have very little data from HIV negative women using PrEP throughout pregnancy. And we know that HIV infection itself, as well as women using ART are using multiple different drugs and from different classes of antiretrovirals. And so the data we have are in a context which is quite different from a woman without HIV who would use tenofovir as PrEP. And so we have very little data, but we do have opportunities in demonstration projects to collect more data and report on it from women using PrEP throughout pregnancy.
That's terrific. I will just flag for folks, a couple of people have sent in notes saying, well, what might be implications for the dapivirine ring, which we talked about on the webinar a couple of weeks ago. And some of you may be aware, and just last week, the Microbicide Trials Network and AVAC co-hosted a small consultation for researchers, advocates, and ethicists looking at the possibility of an MTN study that's in development to look at the dapivirine ring use in pregnant women. And I think this is a great example of the field learning in that trying to collect data faster with respect to dapivirine ring than we were able to do with oral PrEP. And it really was a lesson, I think, learned as we sit here now almost 7 years, I believe. It'll be 7 years in July since Renee and her colleagues in the Partner PrEP study presented the findings of the initial Partners PrEP efficacy results. So how do we get faster, and hopefully we won't be waiting 7 years to have this conversation about the dapivirine ring. So just an additional point there. There was one other quick question I wanted to throw out there before I'll open the line, and it relates, and I don't know, Kerry or Renee, if either of you have thoughts on this, is will you or have you looked at the potential biologic factors why acquisition was increased in late pregnancy particularly? Was it around the vaginal microbiome, hormonal issues, and related with postpartum women, do you have a sense of the difference between these findings in breastfeeding women compared to perhaps non-breastfeeding women? So a couple of questions about biology.
So maybe I'll just say that I think that the questions about biology are really important to understand. Kerry and I don't have any studies that we are planning or that are funded right now to do that, but I believe that there are some basic scientists who are looking into this, and I think it's a great area for exploration, especially if when it can be exploration to think about possible ways or therapeutics to decrease the risk that might be brought on by changes that are due to pregnancy itself.
Great. I don't know if Kerry, if you want to add anything, but I'm going to pause to see if anyone wants to hit *7 to unmute your line. I would ask that you introduce yourself, and I'll let you ask questions. I've learned to pause a little longer just in case. Anyone coming off of mute? All right. No, that's absolutely great. A question did come in electronically, which I'll go ahead and put out, and that relates to do we know anything about adherence with respect to PrEP use in pregnancy? And again, I know you said, Renee, there was, we had limited data. It's beginning to get collected in demo projects, but someone did ask, do we have any initial insights? Is it might adherence be higher or lower depending on this? And just don't know if you have any thought on that.
Yeah, just to say that I don't think we have much data yet across,
Hello.
The studies are still ongoing and the ones that are coming out are still pretty small. So I think that is something that's very important to wrap into studies and program data to be able to measure adherence during pregnancy so that we can contribute that to the field, because I don't feel like we have good data about that yet.
Okay. Fantastic. I think someone was trying to get on. Go ahead.
Morning, Michelle.
Hello there.
Hello.
Is that Paul?
This is Paul Sixpence from Zimbabwe.
Fantastic. Welcome, Paul. Go ahead.
Many thanks. I just wanted to find out, because there's always been debate around hormonal contraceptives also increasing the chances of women contracting HIV, and this study proves that women are more susceptible to contracting HIV during the postpartum phase. And I just want to find out from the researchers that did they find any link to say that probably maybe women on hormonal contraceptives were the ones which were more susceptible to HIV infection, or they did not, that particular aspect was not part of this particular study? Many thanks.
Great. Thanks so much, Paul. Renee, do you want to take that?
Actually, this is Kerry.
Kerry, go ahead.
I'll just start first with some of the statistical specifics for the study that we were presenting today. That is a really good question, and when we start talking about pregnancy and postpartum and all of the hormonal changes that accompany those periods, as well as the changes in prevention behaviors such as hormonal contraception, that has also been in much discussion in the HIV community. This is a question that often comes up, so thanks for asking. In the particular analysis that we've presented today, we were really only looking at pregnancy and postpartum as the exposure, the potential risk. We did not dive into the potential risk associated with use of hormonal contraception. Those are really a separate set of analyses that other colleagues have worked on, including Renee, who's here today. The reason why we haven't addressed it in this particular analysis is because, statistically speaking, to be adjusting for hormonal contraception, we would need to have women in all of our different exposure groups who are using hormonal contraception. And by definition, when women are pregnant, they are not using hormonal contraception. And so we weren't able to adjust for hormonal contraception here. And so we're really looking at separate studies to be addressing the question of what the increased risk is between hormonal contraception and HIV risk. And we're going to have some results coming out soon from a randomized control trial that addresses that specific question. So that's how it pertains to the statistical methods of what we've presented here. And then I'll ask Renee if she wants to add anything else bigger picture.
I think Kerry, I'll just mention that understanding whether any specific hormonal contraceptive increases HIV risk is a huge priority for women's health. And Kerry alluded to the ongoing randomized trial that will look at some specific effective contraceptive methods and HIV risk. And that's happening in South Africa, Swaziland, Kenya, and
Zambia.
In Zambia, sorry. And I know that AVAC is also following quite closely and posting on their website with updates. And we should have results from that trial. I think they're expected sometime next year.
That is exactly right, and that is the ECHO trial. And we've had a series of webinars, and we're actually planning another one coming up soon. And I will just take the opportunity to say how a lot of these pieces do come together. It was a great question, Paul, and it just highlights how any one study really continues to generate new insights. And as much as we talk about the Partners suite of studies, both Partners in Prevention and Partners PrEP, that had primary questions looking in the one about HSV and HIV, and the other looking at oral PrEP. I can remember when a leading researcher named Renee Heffron, who happens to be on today's call, presented some of the findings looking at the increased risk with certain contraceptives, including Depo-Provera, coming out of the Partners study. And that was, observational and one piece of the puzzle that led to the development of the ECHO trial design and the need for a trial like ECHO to try to provide greater clarity. And I think, as we saw today, that what Kerry presented coming out of both of the Partners studies again generates an incredible amount of information that allows us to really think about programs and policies as both Kerry and Renee described. So just really enormously grateful for these studies that continue to give so much important information about women's and men's health and what we need to do to act on these findings. And I want to thank you both very, very much. It also highlights I have up on the screen here the next in the series. We are also trying to schedule one related to all of this, and that is all of these different kinds of research studies. So both partner studies were large randomized controlled trials. Many of these analyses, though, come after that, and we're looking at a webinar soon coming out of CROI about looking at different research methodologies and how they are used to answer different kinds of questions. And hopefully that will be scheduled in a couple of weeks' time. But next week, to connect the dots on some of the oral PrEP experiences, is a webinar, same time next Wednesday at 9 a.m., looking at the various frameworks, tools, and resources to help some of these PrEP programs, not only around PrEP in pregnancy as Renee and Kerry described, but looking generally at how PrEP programs might learn from each other in real time. And so that's coming up a week from now. And we'll let you know about the one on research methodologies hopefully shortly thereafter. Really want to thank all of you for joining. Amazing questions. And just want to give Kerry and Renee one last chance. Any last thoughts or calls to action that you would want to make sure that advocates from around the world would hear from both of you?
Thank you for the opportunity to wrap up with some closing thoughts. I think what I would encourage people to think about is the latter part of the presentation where Renee really highlighted where some of the guidelines are, and just remembering the synergy between how guidelines are written, but then sometimes, oftentimes, new information is forthcoming that makes us take a critical look at those guidelines and advocate for changes that are more aggressive in terms of HIV prevention and capturing missed opportunities. And then also the importance of keeping track of how guidelines are actually being implemented and making sure that even though something is, written down in the documents, it's actually happening in the clinic, in the field, and we're actually harnessing those opportunities to identify infections and prevent new infections from occurring.
Great, Kerry, so well said. Renee, any last thoughts?
I just wanted to thank you, Warren and Mitchell, and to thank everybody else for joining. I think that your attention and your interest in the webinar and your attention and just taking an hour to think about this and really think about the gaps and how we can improve and decrease those gaps really is great and is really important for the field. So thanks so much.
Great. Well, thank you, Renee and Kerry, both starting your day, Kerry, and not quite ending, but in the late afternoon of your day, Renee, and just grateful to both of you and everyone in between. Again, next week, same time, to continue the exploration of oral PrEP. We'll be following up after that with the research methods piece. And just to give you all a coming attraction, of course, we stand here in almost mid-April and just about a month away from the annual HIV Vaccine Awareness Day. And as those of you on the line will know, we often do one or more calls looking at some of the hotter topics in HIV vaccine research and development. Because at the end of the day, if there's anything one takes from what Renee and Kerry presented, is that we need multiple approaches to deal with this epidemic, and that means PrEP and the vaginal ring and partner testing and contraceptive choice and eventually an HIV vaccine as well. So hopefully we'll connect all of those dots over the weeks ahead, and want to thank everybody again for joining, and look forward to talking to many of you or all of you next week on the next webinar. Again, thanks so much, Kerry and Renee, and have great days.
Okay, bye-bye.
Cheers all.